I don't know. Oh. Hello, and thank you for coming to this final session of the TEPHINET Conference, titled Emergency Response Initiatives to Address Natural Disasters and Cross-Border Connectivity. We're very excited about this panel, bringing together representatives from Africa and South America. We've designed this session as a forum to discuss ways to address border health strategies in a variety of contexts. I also want to note that we're excited that a majority of the speakers represent FETP in their countries, so we have that perspective. I'm Dr. Rebecca Merrill. I'm from the U.S. Centers for Disease Control and Prevention, from the Division of Global Migration and Quarantine. So my group works with ministries of health and their partners to address and strategize for improved surveillance, preparedness and response, and cross-border collaboration activities, with a big focus on how to integrate population movement into designing those strategies. And this session really follows very smoothly from Dr. Babatunde's keynote presentation this morning. So we're excited to kind of dive into that topic through these presentations. After all the presentations are complete, we'll then have a hopefully lively question and answer session to round this out. And I'll turn this to Sadie Ward, our co-moderator, to begin introducing the presenters.
Good afternoon, everyone. Thank you for joining us today. I am Sadie Ward. I'm also with the U.S. CDC Division of Global Migration and Quarantine, working with partners to build border health system strengthening. So I'd like to take this opportunity to invite our first speaker, or introduce our first speaker. Ms. Lydia Nakiire is from the Uganda Ministry of Health, is a graduate of the Uganda Ministry of Health Public Health Service Fellowship. She currently works as an epidemiologist with the Infectious Diseases Institute under the Global Health Security Partner Engagement Project. She is providing support to the Ministry of Health to establish a border health system and strengthen public health surveillance systems and outbreak preparedness and response. She is currently supporting the Ministry of Health in their Ebola preparedness efforts and is the IDI Infectious Disease Institute EVD coordinator. Please welcome Ms. Lydia Nakiire.
Good afternoon, everyone. I'm here to present emergency response initiatives to address natural disasters and cross-border connectivity in Uganda. Lydia Nakiire, as already introduced. Okay, thank you. International Health Regulations 2005 emphasizes that international transport, trade, and travel contribute to economic development and welfare of the populations, but we know that this may pose risk to the populations. International Health Regulation 2005 requires that we build capacities at points of entries to prevent, detect, and also provide public health response to international spread of disease in accordance to public health risks and also to avoid unnecessary interference with trade and travel. The Global Health Security Agenda is an effort by nations, international organizations, and civil society to accelerate progress towards a world safe and secure from infectious diseases, to promote global health security as an international priority, but also to spark progress towards full implementation of the World Health International Health Regulation, the World Organization for Animal Health, OIE, through the performance of veterinary services pathway and other relevant global health security frameworks. Population movement has been tested in a study that was done by Stoddard and others. They found that cross-border movement is associated with exposure to disease. This was a study that was done in malaria, and it was found that daily movements normally cause local exposure. That's within villages, because we noticed that our borders have very close relationships between the different people across the borders. You find that families are living across, but they are closely related to the people who are next across the border. So this was found in this study to cause local exposure within the villages. And then for temporal, there was spatial exposure. And then for long term, there was a tendency to cause global spread of malaria. In Uganda, we conducted a joint external evaluation, and we found that performance in emergency response operations ranked really so highly, where we, in capacity to activate emergency operations, scored 3. Then EOC operation procedures and plans, we also scored 3, and same to emergency operation programs. And case management, procedure implementation for IHR relevant hazards, we actually scored highly. We scored a 4. However, when it came to points of entry, we almost had no capacity. Routine capacities at points of entry were not there, and we scored no capacity, which is a 1. And then effective public health response had a similar score. According to IHR 2005, we are required to build capacities at points of entry to prevent international spread of public health events. And also IHR requires that we develop capacities required at all times in order to respond to public health events. Border health services are therefore critical to ensure that adequate national capacities are strengthened for IHR 2005, and also streamlining international travel requirements while minimizing the risk of international disease spread. When the Ebola outbreak started on 1st August 2018, Uganda Ministry of Health was already doing something about border health. Efforts were underway to strengthen border health. And the outbreak was an opportunity for Ministry of Health to strengthen border health and also test the plans that were in place. Uganda identified gaps, and with these gaps, we were able to build on it and develop capacities at points of entry. With regards to core capacities at all times, Uganda has a very porous border, but there was need to prioritize points of entry. And the key priorities that we looked at as a country were providing health services for travelers through identification of sick travelers, then isolation and notification and referral. We had to make sure we identify a referral mechanism to the nearby health facility, which was designated to manage the cases. And then also the issue of decontamination, de-insecting, and deratting was taken into consideration. However, something to mention here is that with regards to Ebola viral disease response, we had to prioritize points of entry. So some of the capacities were not applied. The main capacity that we applied was to provide health services to travelers by screening them, isolation, and then referral. Then another capacity that was built was staff training on Ebola viral disease to quickly identify any cases who could be crossing. Training facilitated coordinated response, preparedness and response to public health events at all times and by all stakeholders, because the trainings were multi-sectoral. We targeted the health team that was at the points of entry, but also other stakeholders like immigration were targeted for these trainings, security, so that it's a holistic approach to response. Then procedures to prevent transmission of communicable diseases through points of entry during routine and response operations were emphasized. Then the capacity to respond, IHR required that designated points of entry have capacity to respond to public health emergencies. Contingency plans needed to be developed or updated based on assessment findings. Then risk assessments were also done to enable targeted interventions for efficient use of public health resources. Timely cross-border and regular regional collaborations were another strategy that we looked at as Uganda. And this was mainly through cross-border meetings that facilitated information sharing and joint planning. Then it also gave a platform to develop a memorandum of understanding between Uganda and DRC. But something to note here is that the MOU is not yet signed, but it's already developed. So with regards to population movement across borders, assessments, it was a participatory approach, and it was supported by CDC Border Health Team. We used qualitative methods where we engaged the communities at different levels, at district, community level, and we also engaged people at the different points of interest. Depending on how information comes out, we would go on to include the necessary groups into the discussions. And high-risk points were identified using movement patterns and connectivity. To date, we were able to do the assessment for all the border districts on the border of Congo and Uganda. To my left, the districts that are red were the districts that were categorized as high-risk districts. But in Uganda, we also have mass gathering that normally takes place during the June 3rd for the Uganda matters. So we were able to use similar methods to do preparedness and response efforts at our mass gathering that takes place during the Matters Day. Some of the key achievements were we were able to geocode points of interest, and with this particular map, we see points of interest for people who move for economic reasons. This was one of our high-risk districts, Kasese, and we see that people who came from that district normally moved. They moved from Kasese through the different districts, and then they ended up in Kampala, our capital city. And also something to note is that this was, the arrows in red are showing movement back. We would normally have people who come from Congo, and they mainly some of them came from the hotspot towns. So we're able to identify that actually it was possible for us to import cases. And then also other points of interest that we were able to identify included health facilities, markets, and then some routes also for other reasons why people are moving. We were able to find out that actually people moved for many other reasons apart from trade. People moved also for familial reasons. People moved for religious reasons, like for example, the mass gathering on 3rd June. And through the efforts of population movement, on 11th June 2019, Uganda announced importation of an EVD case with one sample testing positive for Ebola Virus species. And to date, Uganda imported 4 cases. Case 1, case 2, and case 3 were from one family. And this was elaborated much more in the morning session about the index case who was moving with the mother, and they found that the 5-year-old was also sick, and they ended up in a facility that was identified during the population movements. Then case number 4 was a 9-year-old female who was Congolese and was identified in August through one of the priority points of entries that was identified. Unfortunately, all our imported cases were died, and they gave us a case fatality rate of 100%. This is a map of one of the regions where we did population movements, and the key things that we found were the points of entry where most of the people were passing to come through from Congo to Uganda, and also vice versa, to come from Uganda and go to Congo. We also found the priority health facilities where these people were going, because one of the main reasons why people were traveling to Uganda was to seek care. And then markets for trade. And then also we found that while they are moving, they also had major towns where they would stop. So all these were identified, and all this information was provided for planning. And similarly, we also did the same in Arua, in one of the districts in West Nile, where we identified the high priority places where people were traveling to from Congo, and mainly from the hotspot towns. And this helped us to target our interventions. Some of the key achievements during the efforts to strengthen border health in Uganda, we have found that we had to write up the National Health Security Plan. And one of the key areas that was prioritized in the National Health Security Plan was points of entry in order to strengthen capacity to respond to public health events. And out of this, we have also been able to designate 3 points of entry, including Entebbe International Airport and 2 other ground crossings. Then Uganda and DRC developed a memorandum of understanding. However, something to note here is that it has not yet been signed, but it's already developed. Then Uganda Ministry of Health developed guidelines for Ebola viral disease surveillance at points of entry, then cross-border surveillance strategies through data sharing on cases and contacts. Some of the public health actions that were taken following results from population movements, cross-border collaboration through meetings and data sharing was much more emphasized. And then PopCab results also informed planning for the limited resources at both national and district level. The key examples that we cited out were vaccination committees were able to select the high-risk health facilities for selection of targeted health workers, because we know that the Ebola vaccine was actually limited and we could not vaccinate all the health workers. But for us to be able to be effective, we had to target the high-risk health workers. And it was through the PopCab results that we were able to identify where to pick the health workers from. Then informed the risk communication teams on the high-risk communities where they would target the interventions initially in the initial stages. But for some districts like Kasese, where we actually imported cases as the outbreak went on, we had to identify more and more communities. But for a start, the high-risk communities were identified using the population movement information. Then prioritization of points of entry and health facilities. This definitely came out because it's information that came out from our interviews. In conclusion, cross-border movement was found to be, cross-border movement occurs daily, temporal, and also long-term, and highlights that disease is spread by who, where, and how populations move across the borders. It also highlights the need to incorporate cross-border strategies into public health action plans and to prevent, rapidly detect, and respond to public health events and stop transmission at source. I acknowledge the following. Thank you.
Thank you, Lydia, for that excellent presentation. I'd now like to introduce our second speaker, Ms. Anita Samuel. She is an epidemiologist with the US CDC Global Immunization Division's Strategic Information Team. Her primary responsibilities is to improve the availability and quality of immunization data through strengthening of immunization systems. I don't know how I have a hard time with that word. She is currently supporting the Ebola outbreak response as the focal person for the Ebola vaccine activities at CDC's Emergency Operations Center. Please help me to welcome Ms. Anita Samuel.
Hello. So I'd like to start by first off saying that I'm really happy to be here and to be learning from the FETP graduates and everyone in this room. I do want to start with a caveat that I am a stand-in for Rosalind Carter, who's currently in South Sudan, supporting more of our preparedness activities. So I will do my best with this, but I beg your forgiveness in advance. So to start out with a little bit about Ebola, it was first discovered in 1976 near the Ebola River in the Democratic Republic of Congo, hence its name. And since then, outbreaks have occurred sporadically in Africa, with the continuing most recent outbreak in 2018 that continues to this day. It is a zoonotic RNA virus. So I'm going to go through this and try to leave as much room for my remaining panelists as possible. But again, happy to answer questions later. So we're going to go through a little bit about the Ebola virus disease, EVD, and the current outbreak. I'll talk very briefly about the experimental Ebola vaccines, and then go over a little bit about how it is used currently in the compassionate use protocol in Uganda. And I'll build on a little bit what you've already heard my panelists before me talk about the work that's happening in Uganda. And then we'll talk a little bit about how it's used for microplanning and some future steps. So the Ebola RVSV-ZEBOV vaccine, this is created by, it's currently being developed by Merck, and it is an unlicensed vaccine. We're expecting licensure hopefully within the next 6 months. And that requires that it has to go under a clinical study protocol that needs to be approved by the IRB and the National Regulatory Authority, and includes informed consent of all participants. And so obviously in each of the countries that is used, including Uganda, this process needs to occur. An important point to note in the Merck vaccine, that is essentially the vaccine I'll be talking about today, it protects only against the Zaire Ebola virus strain. So in Uganda, this compassionate use protocol was approved by both the IRB and National Regulatory Authority in September 2018. And in the outbreak, the traditional use of it, and this follows SAGE recommendations, is to use the ring vaccination protocol. I will not be going into ring vaccination in this particular presentation, but there's a lot of information about it online. So in the case of the use in Uganda, which is a bordering country to the primary outbreak zone in the Democratic Republic of Congo, we focus on healthcare and frontline workers on the facilities with the border of the DRC health zones where there is active Ebola transmission currently occurring. So one of the things that we face, and again, Lydia mentioned this before, is that there's a limited amount of vaccine available for countries that are in the preparedness activities and that are not currently experiencing active transmission. So in order to decide how to allocate the vaccine, the National Task Force in Uganda determined that there were 13 high-risk districts, and these border Lake Albert and Lake Edward. And so then in order to best utilize the vaccine and make sure that the most at-risk population received it, the resources were allocated for border health screening at the points of entry. So a little bit about this, but again, Lydia did a great job before me. So POP-CAB implementation. So there were at least 20 events completed. And you'll see here some of the districts. I won't go through all of them, but important to note in all of these activities are obviously the stakeholders that you involve in each part of the process. So in this, we have our health workers, our surveillance officers, our village health volunteers, our herbalists and traditional healers, immigration officers, police officers, security officers, and our transporters. It stopped working. Oh, there we go. So this is an older map. But we do use these when we start working on this process of how to identify which health facilities to prioritize in the high-risk districts. So this is an illustration for all of you. One of the things to note that this is only partially filled out, we recognize that there are other partners that have more detailed maps as well. So this is a map showing some population movement between, so what we see in the pink, I believe, looks like, okay, great. So in the pink, or the lighter color, is essentially what we assume based on the health system where people would seek care. So this would mean that when people cross the border, they would go to Butembo to seek care at the health facilities there. I believe it's Butembo. Am I reading it incorrect? Bawera, yes, apologies. Now, what the information we get from all of our stakeholders helps inform the red line. So that's actually where they do seek care. That's the movement of the population, and in fact, it appears that most of them prefer to seek care at Kagando Hospital. I need to get my eyes checked, obviously, but at Kagando Hospital. So this gives us a better idea of when, our Ministry of Health officials, where they believe people seek care, again, is shown by the pink, but then where they're actually going helps us then modify the response efforts appropriately. And you'll see right there, this is obviously a border area with DRC. So again, just to go through this a little bit more carefully, but how do you select these health facilities? Because again, the vaccine that's currently being used is an investigational product. It does require consent. And since there is such a limited supply, we do want to make sure that we really do prioritize the frontline and healthcare workers that are at most risk of encountering a potential case of Ebola virus. So the first step is to create a comprehensive list of health facilities in that high-risk district. And then from there, we add additional relevant data sources to differentiate. And then, of course, this is where we really do rely on our stakeholders. And then once we have that, we try to balance the health centers, the 2, 3, and 4, and hospitals. And then again, we try to include health posts as well as the district hospitals in this. Now again, since this is trying to think about mobility and how populations move, the way we think they move versus the way they actually do, we of course consider the roads and accessibility, and then of course at the end, review with the government. So this is a very recent map that shows where we are currently in the outbreak. We are very happy that the number of health zones in DRC are reducing, but we do notice that there is continued persistent transmission in DRC, which of course means that our activities in our preparedness countries is ongoing and the support that we provide. What you'll see there is on the Uganda border, it's a very porous border, as noted before, but it is, again, closest to a lot of our active areas of transmission at the moment. And this was just the 8th of October. Oh, I didn't know this popped up. This is when it's not your slide set. So there are over 3,000 cases with 2,000 deaths. There are 23 health zones currently affected, though that is decreasing. And we are very happy that at least 230,000 people to date have been vaccinated. We are working, CDC, along with our other US government colleagues and WHO, to scale up the manufacturing need. Again, Merck has limited supplies right now, but that should be increasing by next year. And we are hoping to get more vaccine to countries that need it. So I will end with I believe these are pictures near the end of mine. So this is a vaccination station. This is another map showing the border. And again, most of the cases that we're worried about right now in DRC are at that border with Uganda. We're showing the population movement. So we are continuing a lot of our preparedness work in South Sudan, which is to the north of Uganda, and then down to Rwanda as well, and Burundi. So in the case of all of these bordering countries, also known as preparedness countries, we have vaccinated so far, and the countries have done a wonderful job in 16,000 healthcare workers at high risk of encountering Ebola. So during ring vaccination, when there is a case identified, we do send teams out to the communities with a recently confirmed Ebola case. This is when the surveillance process initiates, as well as identifying immediate contacts of that case and contacts of contacts in order to make sure we have community-wide protection. And then once again, we had used the data that had been mentioned before, population movement, to be able to identify high-risk healthcare workers at these border health facilities. This is an example of some preventative work that happened in Uganda. And that's it. Thank you.
Thank you, Anita. Our next oh no, sorry, I just lost his bio, excuse me. So our next presenter is Mr. Jadher Percio. Thank you, I said that correctly. He is a nurse with a master's degree in public health and is pursuing a doctorate in tropical medicine. He's a field epidemiologist who graduated from the Field Epidemiology Training Program from the state of Sao Paulo and has served as coordinator of FETP Brazil, or EpiSUS, since May this year. He has participated in several field investigations, having worked on the Zika virus and its consequences, yellow fever, measles, among many other public health emergencies. Welcome.
moment. Oops. Good afternoon, everyone. It's a great pleasure for me to be here and would like to thank you, Rebecca and TEPHINET for this opportunity. I also want to thank in advance all my FTP Brazil team and the technicians who are involved with the situation that I will share with you today. As you can see, English is not my language, so forgive me if I pronounce something not correctly and something is incomprehensible, ask me in the end. Do you have a deal? Good. Brazil is the largest country in South America and Latin America. It is the 50th largest country in the world in territorial extension and population size. Brazil is the only country in the Americas whose official language is Portuguese. Bounded by the Atlantic Ocean to the east, Brazil borders every country in South America, except Ecuador and Chile. Brazil is a federative republic formed by the union of 26 states, a federal district, and more than 5,500 municipalities. Geographically, the country is divided into 5 major regions, as you can see on the map. Brazil is once considered the largest economy in Latin America and was estimated in 2017 to be a gross domestic product of approximately $3 trillion. Its development index is considered high. However, Brazil is marked by large social inequalities and economic concentration. To minimize the impact of social inequalities of population health, Brazil has adopted the redistributive model of social protection to finance its public health system. Implemented in the year 1990 and called SUS, its fundamental principles are universality, which guarantees free service to anyone who is in Brazilian territory, including foreigners. It is in the context of SUS that the Field Epidemiology Training Program of Brazil, which is called EpiSUS, is inserted. EpiSUS was implemented in the year 2000 at the advanced level, at the federal level of government, and in 2017, the frontline level was started. The intermediate level is in the implementation phase, which is expected to occur next year. EpiSUS, in the wake of public health emergencies, supports states and municipalities in conducting epidemiological investigations. Well, now that you know a little about Brazil and its healthcare system, I will present our action on the emergence of measles in the country and its relationship with migratory movements in your territory. In this historical series from 1917 to 2017 in Brazil, we can observe the trend of measles incidence in the red line, measles vaccine coverage in the blue line, and the main control strategies adopted on the green arrows. Initially, it is observed that with the increase in vaccination coverage and the implementation of follow-up vaccination campaigns, we have been able to reduce the occurrence of autochthonous measles cases. The last autochthonous measles cases in Brazil were reported in the year 2000. However, the imported cases have been continuing identified. From 2003 to 2012, measles vaccination coverage begins to fall below the 95% target, culminating in a major epidemic in the Northwest region. Between 2013 and 2015, resulting for imported cases in 2 states, Pernambuco and Ceará, with more than 1,000 cases of measles. Fortunately, this epidemic was controlled before measles circulation was again considered autochthonous. Thus, in 2016, the Americas region was declared measles-free by the Pan American Health Organization. That same year, based on lessons learned from its latest epidemic, Brazil published the Measles Contingency Plan to direct preparedness and response actions in the context of public health emergency management. Meanwhile, Venezuela was facing a several political, economic, and social crises, which culminated in an intense refugee migration movement to its neighboring countries. Colombia received the most Venezuelan migrants, followed by Peru, Chile, and Ecuador. By 2017, Venezuelan migration to Brazil had increased by over 1,000%. The main destinations of these migrants in Brazil were the states of the states of Amazonas and Roraima, as they border Venezuela. Initially, Venezuelan migrants were placed in temporary shelters and camps. The explosive increase in the local population due to migrants resulted in the overload of municipalities' public services, especially health services, which were not prepared to absorb this increasing demand. In Venezuela, the main endemic diseases at that time were very similar to those in Brazil, such as dengue, malaria, chikungunya, yellow fever, and tuberculosis. However, as of August 2017, Venezuela has begun to identify measles cases, genotype D8. Roraima was the Brazilian state that received the most Venezuelan migrants. As a result, in September 2017, a FTP Brazil team was sent to the camp to conduct two surveys, one among the sheltered migrants and the other one among the non-sheltered migrants who were living in the public highway near the interstate bus station. The guide question was, what is the socio-demographic and epidemiological profile of these migrants? In this photo, you can see our team that was sent to the field. In these pictures taken during the field work, you can see both our team working and the conditions under which Venezuelan migrants were living in Roraima. Well, I will present a brief summary of the main findings of this research. A total of more than 400 Venezuelan sheltered migrants were interviewed. The median age was 23 years old, and 60% were male. Of everyday respondents, 7 were indigenous. For 21% of respondents, the main reason for migration was lack of health care. Of the total, only 7% had been vaccinated for measles. However, no suspect cases, measles cases, were identified at that time. Regarding non-sheltered migrants, more than 200 people were interviewed. The median age was 32 years, and 71 were male. Of everyday respondents, 1 was indigenous. For 10% of respondents, the main reason for migration was lack of health care. Of the total, only 14% had been vaccinated for measles, and no suspect measles cases has been identified at that time. The first case of measles in Roraima, Brazil, was reported on February 12, 5 months after the survey. It's a Venezuelan child under 1 year of age and no vaccinated. 4 days after this notification, a FTP Brazil team was sent to the field to search for new cases, pick up and track contacts, and identify measles transmission chains. With the reintroduction of measles in Brazil from cases imported from Venezuela, we experienced a major epidemic in the year 2018. In total, more than 10,000 cases of measles, genotype D8, were confirmed, compatible with cases from Venezuela. The epidemic was concentrated in the northern region of the country, and 95% of the cases were residents of the state of Amazonas. The epidemic began in February 2018 and peaked up in July. Last related cases occurred a long year after, in February 2019. Vaccination is the main strategy for measles prevention and control. At that time, the Ministry of Health distributed to states more than 32 million doses of measles vaccine. A little more than 13 million doses were administered in campaigns, vaccination of contacts, and routine vaccination. In the 2018 measles epidemic, FETP Brazil had 13 training professionals, and they participated in various ways in response to this public health emergency. In March 2018, a month after the first measles case was reported in Roraima, Brazil's federal government began Operation Welcome. It's a humanitarian logistic task force led by the Brazilian Armed Forces with the integration of several other sectors, including health. Operation Welcome continues to operate today. This strategy has three pillars, which are reception, which includes vaccination of migrants, the shelter, and internalization. To illustrate the work done by Operation Welcome, note in these pictures what the situation of migrants was like before the humanitarian mission and what it was after, beginning with the welcome stage, where migrants are welcome. Regarding the shelter, one can observe how the conditions of temporary housing were before and after the intervention. And finally, a little about the internalization, which includes the transportation of the shelter in Roraima to other states of the country where these people will have the opportunity to rebuild their lives. Well, after controlling the measles epidemic in 2018, we were surprised by a new wave of measles epidemic in 2019. But this time, the scenario was totally different. This figure illustrated the worldwide airflow, which was already intense in 2009, and demonstrates how much we are globally connected. In Brazil, for example, in 2018, there were more than 11 million international landings and almost 100 million domestic landings. This, the introduction or dispersion of known or unknown etiological agents can occur more easily and quickly, as we know. Sea travel also has a large flow between countries and continents, as we can see in this figure, which represents the worldwide sea flow in 2012. It is important to highlight that the incubation period of the etiological agents can provide the maintenance of the circulation of an agent throughout the journey, even for long periods of time, while there are susceptible persons on board. Well, in February 2019, a transatlantic cruise ship from Malta arrived at the port of Santos in São Paulo, in Brazil. When the ship arrived on the Brazilian coast, he notified the authorities of 13 suspect cases of rubella, which were placed in isolation and laboratory tests. The blood test was negative for rubella, so the ship went to Santa Catarina, further south. However, as in Brazil public health laboratories make the differential diagnosis for Hush syndromes, the samples were tested for measles and found positive. Then, when the ship arrived in Santa Catarina, 1,300 crew members were vaccinated with the measles vaccine. Even so, the ship continued its course and returned to Santos in São Paulo 5 days later, where the local team vaccinated 90,000 people who boarded and disembarked from the ship. However, this control action was not timely, and the affected people who were in the incubation period and arrived in São Paulo eventually spread the virus. At the same time, 2 important measles cases that arrived in São Paulo by air from Israel and Norway were identified. The genotype identified as also the D8, but genetically it was different for the one circulating in Venezuela. This situation, associated with the accumulation of susceptibilities in Brazil, whether due to low vaccination coverage or individual vaccine failures, was enough to trigger a new epidemic wave of measles in the country. By the end of September, more than 6,000 measles cases had been confirmed, with 6 deaths. In 2019, measles cases were mainly concentrated in the southwestern region of the country, with 82% of cases reported in the state of São Paulo. To date, in 2019, the Ministry of Health has distributed to states more than 34 million doses of measles vaccine, of which slightly more than 15 million doses have been administered in campaigns, vaccination of contacts, and routine vaccination. In the 2019 measles epidemic, FTP Brazil had 80 training professionals, and they participate in various ways responding to this public health emergency. In addition, since its inception, EpiSUS Frontline has been conducting classes with some border countries, such as Peru and Colombia in 2017, and Bolivia and Argentina this year. By 2020, another 10 classes are planned to be held, where the main health problems that are common among our countries are discussed. To finish, measles is a worldwide problem today, which is present in both developed and developing countries. Considering that our resources are limited, that vaccination coverage is decreasing, that the measles virus circulates in different parts of the world, that borders do not give barriers to ecological agents, and that migratory movements are increasingly constant, I ask you, what could you have done to prevent this situation? Today is measles. Tomorrow what? Well, I believe global problems require global preparedness and response actions. In this sense, as a global FTP network, I would like to suggest some capacity building and cooperation actions to discuss this together, such as FTP exchanges, joint simulations, contingency planning, the provision of specific border area mini-grants, joint field work in the event of emergencies, and timely sharing of strategic information. Thank you for your attention.
Obrigado. So I'd like to introduce our fourth and final presenter of the day, Ms. Cynthia Sema Balthazar. Oh no, I just lost my thing. Is from the National Institute of Health in Mozambique, where she coordinates the field's activities for outbreak investigations and the response to public health emergencies at both the provincial and district level. She supported the implementation of early analysis of surveillance data for the timely monitoring of health risk situations during the Cyclone Kenneth outbreak, or emergency rather, in Mozambique, and the strengthening of the surveillance system after the emergency. Please welcome Ms. Cynthia.
Good afternoon, everyone. Thank you for this opportunity. I think most of you know Mozambique because we host the last TEPHINET conference in November 2018. And because I'm the last speaker, and I know all of you at this moment, you are just thinking about your words, I'm not going to do a presentation. In fact, I'm going to tell a story. It was 7 p.m. on March 14. Idai cyclone was arriving in Mozambique. Heavy rains and strong winds up to 180 kilometers was what people lived faces. The most affected people were from Beira City, the Mozambique fourth largest city, housing 500,000 people. After the cyclone, there was a week of heavy rains and flooding across southern East Africa, affecting Mozambique, Zimbabwe, and Malawi. In Shona language, Idai means love them, but for us, it became a synonym for a destruction. The cyclone has destroyed 90% of Beira infrastructure. Over 600 people were killed and 400,000 displaced across the region. Idai blew over Beira and then moved inland all the way to Zimbabwe with impacts stretching up to Malawi. It was a massive destruction. All communications lines were completely cut off. The main roads were destroyed. Public and private infrastructure, including schools, hospitals, and houses, were destroyed. Beira City, as other districts, become a ghost town during the night because there was no electricity. The cyclone substantially damaged the city water supply. Many people had no access to clean drinking water. As you can see on this satellite picture that shows the before and after the cyclone, a scope of massive flood described as an inland ocean. The president of Mozambique declared a state of emergency on March 19. The situation was even more precarious in the vast countryside surrounding Beira. Roads were flooded, and most affected towns were unreachable to the emergency responder. So 6 FELTP graduates from the Mozambique FELTP were deployed to Beira City short after the traffic has been restored. It was in 48 hours. Their main task was to conduct risk assessment, daily disease monitoring, support the screening of people rescued from the affected areas, and investigate rumors and possible outbreaks. Getting information was extremely challenging during the first week because most of healthcare infrastructure were damaged, health staff were not able to deal with the situation, therefore the surveillance system was not functional. So during the first week, the FELTP support the reestablishment of the surveillance system. They create a data collection form where priority diseases were defined and could be systematically monitoring. The list of priority disease was formulated taking in consideration the epidemic potential, high morbidity, high mortality, availability of prevention and control measures, simple laboratory diagnosis when it's appropriate, and also the international health regulation. Initially, the system was paper-based, but a few days after, when the communications start to be restored, it was implemented the electronic surveillance system. Most of you know has the AWARS. With AWARS, the epidemiologists could easily track and report rumors of the disease, develop a real-time dashboard that allows them to timely detect possible outbreaks. With infrastructure damage, the people living in temporary shelters, plus unsafe water and poor sanitation create the perfect recipe for increasing waterborne disease. On March 27, nearly 2 weeks after the cyclone, the Mozambique Ministry of Health declared the cholera outbreak. A total of 6,768 cholera cases and 4 deaths were reported in 4 most affected districts. The surveillance system implemented in the FELTP activities contribute with accurate data to describe the outbreak and was crucial to inform interventions. The link between the surveillance and WASH activities with also oral cholera vaccine was the perfect equation to end up the cholera and also prevent the occurrence of outbreak in other emergency settings. It was demonstrated how important it is to establish an effective data collection system with clear data flows and well-trained human resources to collect and process the data. It's also important to highlight that the introduction of AORs not only improved the information management system, but also enabled the implementation of a communication strategy to respond for a demand for a fast and quality information that helps to establish a uniform information system flow. Most of you must hear the quote that says, "A disaster never comes alone," don't you? And it was happening in Mozambique. 6 weeks after the cyclone, on April 25, a second cyclone arrived. Cyclone Kenneth hits Mozambique coast on the north side in Cabo Delgado province, affecting near 300,000 of people, and destroy 45,000 of houses, causing a death of 45 people. It was the first time in record history where two strong cyclones have hit a country in the same region within a few weeks. With the cyclone Kenneth, we faced the same challenge. The situation was almost similar. Water sources, crop, building, roads, and other infrastructure were also damaged or destroyed, create an extended and complex emergency response period in our country. The subsequent intensive rain, which lasts several days, disturbed transportation, displacement of families, damaged infrastructure. These also include the healthcare and sanitation. So cholera outbreak was also expected in Cabo Delgado province. But at the time that we were so overwhelming trying to coordinate the FELTP teams in the two provinces, Cabo Delgado and Sofala, that was the most affected province, this news came up in our social networks. This bulletin issued by Zimbabwe mentioned a death rumor of a Mozambican male who died suspected with cholera. The same bulletin stated that this individual lost his life on his way to one of the health facilities in Zimbabwe where we could seek for a better care. It also says that the funeral was held in the Mozambique side of the border. It's important to mention this area is an area very remote. Remember that I told there was no cell phone communication, so we could not confirm if this information by phone. If this information was true, we could be in a situation where a cholera outbreak was emerging in a very remote area. This could pose significant challenge for an effective investigation and rapid response due to the limitation of the resource, personnel, and means to reach this remote area. So we had to urgently send out a team of epidemiologists to assess the situation. Those two amazing residents that you can see there, those two ladies, they travel more than 800 kilometers to reach out to this community. They travel without any communication in a very bad condition roads. The travel took an entire day. Even the tires get flattened during the trip. When they arrive there, they conduct an active search of suspected cholera cases. They revise the health facility logbooks. They also contact the community leaders to investigate possible cases at the community. And they could not find any case. Since Zimbabwe Healthcare Center is 3 kilometers from the border with Mozambique, and because it's a this health facility has been receiving patients from Mozambique, the team decided to cross border to investigate the facts and collect more information that could facilitate the individual identification, including name and residence. For this trip, the team was accompanied by 2 border guards, one from Mozambique and another one from Zimbabwe. After all investigations that were made, it was concluded that was a false news. A school teacher has invented this information about the family debt just because he wants to get a layoff. This simple situation demonstrates how communication between countries can be challenged during an emergency situation. So, health disasters have the potential to reverse. Mozambique is one of the poor countries in the world, is the third highest at-risk African countries most vulnerable to weather-related events such as cyclones, droughts, floods that can result in epidemics. How prepared we are? All of us know that preparedness is the ability to effectively anticipate, respond to, and recover from negative impacts. As you can see on this map, we are classified as one of the countries less prepared to detect and respond to infectious disease events. One way to address the question is through the Joint External Evaluation, the GEE, that helps countries identify the most critical gaps within the human and animal health system in order to prioritize opportunities for an health preparedness and response. Mozambique has conducted the GE in 2016, and we are currently under the final steps for finalization and approval of the National Action Plan for Health Security. But the fact is, the most realistic way to test whether if we are ready or not is when we must deal with the real-time situation as we live with those cyclones. So the cyclone emergency in Mozambique revealed how vulnerable is our health system. A cholera outbreak was contained due to an effective and timely intervention measures adopted by the Ministry of Health and partners. There was no cross-border transmission. The lack of structured communication between IHR focal point sectors challenged the compliance with the international health regulation, particularly in risk communications. It's very important that we develop a more robust long-term infrastructure, early warning, and preparedness system. A resilient health system should have the capacity to effectively prepare and respond to emergency, preserving the key function, health function, and recovering during and after emergency. We have seen different scenarios in sub-Saharan Africa that show how important it is to invest on the FLTP training. As Patrick O'Carroll mentioned on his presentation about the roadmap, it's also important to develop a framework for cross-border mobilization for the FLTPs. We need to come up with mechanisms that ensure rapid mobilization and timely deployment of the field epidemiologists to respond to a public health emergency across our continent. Timely and effective response can ensure mitigation of the health, economic, and social consequences in emergency. A good example of this framework is the TEPHINET corp disease of detection. I finished my presentation to extend my knowledge to all the FLTP residents that were in those two cyclones, in these conditions that you saw, the resident advisors that also support, all the partners, the health clusters in Sofala and health clusters in Beira, in Cabo Delgado, all the partners that support, and special TEPHINET for giving us this opportunity to be here and present this situation. Thank you.
Good. Thank you. Those were very riveting. I didn't want any one of them to end, but we've now come to the time when we can have questions from the audience. We have a few minutes for that, and we can also facilitate a discussion if there's time. But does anyone have questions about any of these? Because I think, oh, yes.
Reina Tercios, EIS, and I'm with CDC Atlanta now. Curiosity, what happened with the teacher who invented this case? What were the consequences? Most importantly, what has been set up so that such an incident is less likely to happen in the future?
Do I respond now? Or
Yeah.
So to be honest, nothing happened with him. He denied all the information, and nothing happened. So we spend a lot of money, send out this team. We put them in a situation very fragile without communication, but there was no further consequence, and there was no plan implementation to further prevent this situation. This is a challenge that we have. That's why we need to strengthen cross-border collaboration, especially between this situation.
I think if you have a question, definitely jump up. But I think that's actually a great segue into a question that we wanted to facilitate. I think the challenge with cross-border collaboration, as you just highlighted, is not just the dynamics at the local level that are built on relationships and kind of can be news-based alerts and just information coming through multiple channels, but then at the national level we have resource allocation and needs for political partnership and strategic dialogue. So I did want to hear from you all, if you could expand on the examples or the suggestions you included in your presentation, or just other ideas that you've had watching these and thinking about your experiences, on how we could really think about sustaining cross-border collaboration when, again, there's informal information alerts that can come through as well as that national partnership. I don't know if maybe you want to continue and then we can go down.
I saw this in very different ways. I will mention some of them. One of the things that I think it's important is that we strengthen our mechanism to share regular and currently epidemiological information between countries, especially when we are in this situation, we need to strengthen up. Because we saw that if we had a very good mechanism to share these informations, we might not be in that situation. So we need to strengthen a mechanism to share the situation. I think also the regional networks, they play an important role on this situation because they can provide joint trainings between the residents and graduates in the different countries related to the cross-border initiatives. So regional networks, they can play a very important role in strengthening the FELTP to respond to this emergency. Also develop jointly exercise to address those same challenges. This is something, develop specific curriculum that can address the cross-border initiatives. I think this is one of my ideas.
Mm-hmm. Thank you. Jadher, I don't...
Okay.
If you're ready.
Me ajuda? I will to speak in Portuguese, and my friend Cynthia translates for me, okay? Então, eu acho que no mundo que vivemos hoje, com tanta facilidade de transporte, onde a gente pode chegar a um país em poucas horas.
So, wait. What Jadher is mentioning, in the modern world that we live today, that we have a facility for the transportation and be communicating between countries, so everyone is traveling.
Nós do FETP devemos estar preparados também para conhecer a realidade de outros países.
So the FELTP needs to be prepared to know the reality from other countries.
E poder nos preparar caso o que acontece nos outros países sejam introduzidos também na nossa realidade.
And be prepared to, in case that something happen in other countries that can be important to our reality. So the FELTP needs to be prepared for this.
E como sugestão, algo que a gente pode começar a implementar é um intercâmbio entre FETP.
So one of the suggestions is that we can implement sharing mechanisms between the FTP's programs.
Por exemplo, o Brasil erradicou a poliomielite selvagem.
For example, Brazil eradicates the wild polio.
Porém, as nossas coberturas vacinais estão diminuindo.
but the vaccinate coverage is decreasing.
E Angola está vivendo atualmente surto de pólio selvagem.
And Angola now is facing an outbreak of polio, wild polio.
Como a polio foi erradicada há muitos anos no Brasil,
Since polio was eradicated a very long time in Brazil,
os profissionais de saúde atuais não conhecem a poliomielite.
so the health staff doesn't know the polio in Brazil.
Então, se pudéssemos trocar experiências, mandando profissionais em treinamento para Angola e eles para o Brasil, essa troca de experiência ia fortalecer.
So one of the suggestions is we create a mechanism to send the residents from Brazil to Angola so they can learn from those experience to be ready for any case that we have a situation in Brazil.
É só exemplo.
This is an example.
Yes, good. Thank you. And Lydia.
Yeah, thank you. With regards to Uganda, I think one of the key things that has helped strengthen cross-border collaboration has been putting frameworks for where the different teams can easily be able to do the operational work. One of the key things that has been looked into as Uganda is to strengthen the border health. Because if I could relate it to a baby, border health in Uganda is a baby who got stunted. Because we had border health, and at some point it's an area that was, I should say, ignored. But right now, with the different threats and the different emergencies, and also following the joint external evaluation, this is something that has been emphasized to make sure there is that structure right from the national level where the border health issues can be handled. And if we have a national structure, then it will be easy for us to create that collaboration with the neighboring countries, but also issues of policy around cross-border collaboration, I think, need to be handled because we don't really have, apart from the East African collaboration framework that we have, with the rest of the other countries, like DRC, which is not in the East African community, we don't have like a formal legal framework where we can operate and share information so easily. So if it's something that is looked into, whereby we are able to put up policies that are able to support such collaborations, I think it's something that is going to strengthen cross-border collaboration.
Thank you. And maybe before you offer, do you want to go now? Okay, I was going to turn to a question.
Please.
Yes.
Oh, well, good afternoon. I'm Lissandro Torre from TEPHINET. Just had a question from all these new experiences, or not new experiences, but experiences with emergency response. What lessons learned are you taking it, or how are you taking those lessons and turning them into something that's useful for training for future FETPs to respond, especially when emergencies have different surveillance systems and epidemiology? So how is this helping prepare for the future?
Directed to Cynthia.
To
Everyone probably, but
all emergencies.
yeah.
Well, in our case, we came up with a lot of lessons learned. For example, I mentioned that we have done the GE in 2016, and then we now are finalizing the National Action Plan for Health Security. But after the cyclones, we need to come back and revise the plan to see if all the points were there to be more prepared. In terms of the FELTP, we also realized that there are some components in the training that it's important to include or to emphasize during the training. And although they respond very well, but the situation was so, was so stressful that we, for example, has only 46 graduates. And each group had to stay there 2 weeks with the very bad conditions. Like there was no water, electricity, and everything. So we came up that we need to revise the curriculum to make, not to revise, but to go back and look if all those aspects to how we need to respond to this emergency situation are there. because we saw that Mozambique is now considered the third African country most vulnerable. So we are expecting to have this situation, even if it's not cyclone, but will be floods or other situation, that they will have to deal with this. And especially the issue of cross-border surveillance, how we can improve. It's something that we also think that so we are now in the process to revise all the contents to make sure that we are covering all the important aspects during the training.
No Brasil, o EpiSUS implementou 2 estratégias com o FTP Frontline.
So in Brazil, the EpiSUS implemented 2 strategies with the FLTP Frontline.
Que tem dado muito certo, que é fazer turmas em conjunto entre os países da América do Sul.
So this has been very successful. So they have cohorts that they jointly Brazil with other countries. Yeah.
E além de ter essa integração e a oportunidade de um país conhecer os problemas que o outro vivencia,
so besides of having this integration of different countries and opportunity for them to know each other's problems,
tem sido incluída nas turmas profissionais que não são da área da saúde, mas que são setores que atuam junto, como o Ministério da Agricultura e da Pecuária.
So they have been also including not only health staff, health human staff in the courts, but also other areas like agriculture.
Vigilância sanitária e profissionais que trabalham com a inteligência do país, como a Associação Brasileira de Inteligência, que é do Exército.
I think you understand.
Enfim, vários setores
So they
trabalhando,
include different sectors,
sendo capacitados em
like
epidemiologia.
agriculture, defense, to be all together on the training.
That's interesting. Yeah, and in the final minute, Lydia, your reflection on the question.
With regards to sustainability for the programs, in Uganda, we already have a framework which we're operating under, the Accord. So if we had a disaster in the neighboring country, Accord is able to mobilize the teams so fast to go and respond. However, when it comes to training, I think, like Cynthia highlighted, I think it's something that needs to be more re-emphasized. As a graduate, we were trained about responding to public health emergencies, but I think this was more tailored to in-country, not really cross-border. So I guess maybe the residents have to kind of be prepared such that at any one time, if they are requested to go and respond in a neighboring country, it becomes easy. But also something that I was thinking about is the issue about language. I don't know if it's something that we can think about as the different programs, whereby we can put an arrangement to provide like language lessons so that I'm able to go to Mozambique and I respond comfortably because I don't speak Portuguese, but I would love to go and respond in Mozambique, but sometimes because of language barrier, we're not able to go. And this was the case also for Democratic Republic of Congo. Response required you to know French, of which it was really a big limitation to most of the graduates. So they were not able to go and respond yet. Actually, they could have responded.
Yeah. Thank you. Yeah, and definitely we want Anita to give any reflections. We appreciate you presenting on behalf of Rosalind. But if you have comments on...
This has been great. I've learned so much from all 3 of your presentations, and thank you so much.
Yeah, thank you all. I think that concludes the session. I have been asked to remind you to rate the session on the app. And other than that, definitely get a little break until the awards ceremony. Thank you.